Welcome to the deep dive. Today, we're really immersing ourselves in, well, a cornerstone topic, neuropsychiatry. We're pulling insights straight from the classic Kaplan and Sadock textbook source material. And our mission today, it's pretty specific. We're not just talking about, general mental states. We want to map the actual intersection between brain disease and behavior. So moving beyond those broad ideas to really drill down into the physical circuits, the diagnostic criteria, and the management strategies that make this field so distinct.
Exactly. And that distinction is, I think, really crucial for you, the listener. Neuropsychiatry pushes us past that, let's call it the soup and neurotransmitters model. The idea that it's all just a general chemical imbalance needing a general drug. No, this field focuses squarely on the psychological, the behavioral signs of actual brain disease. And that demands a much more detailed map, specific circuits, specific systems, greater differentiation.
Okay, let's start unpacking that map, that blueprint. Looking at the brain physically, the two halves aren't identical, right? Let's talk about lateralization. What's a key example of this asymmetry with, real clinical weight?
Well, beyond the ones people often know, like language areas, Broca's area, the planum temporal, usually being bigger on the left, this asymmetry digs deep into basic life support. Take the insular cortex. It handles autonomic function. So the right insula manages the sympathetic drive for the heart, the gas pedal, if you will, while the left insula, it regulates the parasympathetic drive, the brake.
Okay, wait.
And the clinical punchline is this. A stroke affecting the left insula causes significantly more cardiac instability, more problems than a similar stroke on the right.
Wow. So a doctor in the ICU literally has to think differently about managing that patient, not just based on how bad the stroke is, but purely on which side got hit, because one side controls the gas, the other the brake. That's incredibly specific.
It really is. And that specificity, it all comes down to connectivity. Function isn't just in one spot. It runs along these dedicated highways.
Which brings us right to maybe the most critical concept in behavioral neuroanatomy, fronto-subcortical circuits.
Okay, these sound pretty complex. Can you maybe give us an analogy first? How do these things actually work before we get into the parts list?
Sure. Think of them like parallel subway lines, closed loops. They all start at the station, the cortex, and they all end back there. But each line, each loop, is dedicated to a specific job. Maybe mood, maybe planning, maybe regulating behavior. They're not just general pathways. They're highly specific feedback loops.
So the structure usually goes like this. A bit of prefrontal cortex sends signals down to the striatum. Then it goes through the basal ganglia outputs, think globus pallidus, substantia nigra, then to a specific spot in the thalamus. And the thalamus sends it right back up to where it started in the cortex. A closed loop. We really emphasize three of these loops involving the dorsolateral prefrontal cortex, the orbitofrontal, and the anterior cingulate cortex. Disruptions there. That's where you see major problems in behavior and executive function.
Right. And speaking of structures we thought we understood, the cerebellum, for most people, that's just balance, coordination, right? Why is it even part of a neuropsychiatry discussion?
Yeah, that's the old view. But the anatomy, it's undeniable now. The cerebellum has these reciprocal connections, these parallel closed loops, linking it back to the prefrontal cortex. Again, the thalamus acts as the relay station. So this provides the actual physical basis for its role in, thinking and feeling, cognition and emotion. And specifically, the older parts, phylogenetically speaking, the vermis and the vestigial nucleus, they're now often called the limbic cerebellum. That confirms their role in emotional regulation, not just motor control.
That structural map is so important. Okay, let's shift gears. How does this translate clinically? When you're assessing a patient, maybe someone older, but without a dementia diagnosis, what are the subtle signs that point towards an organic cognitive issue versus, say, depression?
That's a great question. We look for specific types of cognitive problems, not just a general complaint of, my memory's bad. Actually, there's this interesting paradox, especially in late-life depression. The more intensely someone complains about memory problems, the less likely it is purely organic. It's often more tied to the depression itself, like poor focus. Yeah. The real clues for organic failure are often about capacity. Are they losing the ability for divided attention? Like, they suddenly realize they can't read a book and listen to the radio at the same time anymore. Or are they starting to rely heavily on notes for everything, writing things down constantly? Or, and this is a big one, getting lost in familiar places. That signals a breakdown in the wiring itself.
And what about problems with recognition? You mentioned agnosia. How is that different from just being confused or even having a language problem like aphasia?
Agnosia is very specific. It's a failure of recognition, usually caused by lesions in the ventral pathway, like the inferotemporal cortex.
Hmm.
So imagine you see a key. You see it clearly, you can pick it up, no problem with vision or movement, but you have absolutely no idea what it is or what it's for. Critically, with agnosia, the person can't name the object, and they can't demonstrate its use non-verbally either. It's a loss of meaning.
A pure recognition failure. Got it.
Exactly. Now, with language, with aphasia, we map that out much more finely across 6 areas. How they speak spontaneously, naming things, understanding, repeating, reading, and writing.
Okay.
So if someone's speech is disfluent, meaning it's short, effortful, maybe ungrammatical that points towards the front of the left hemisphere, or maybe deep structures like the putamen, but if their comprehension is impaired, that suggests damage further back in the temporal lobe. And we also check for something called ideomotor apraxia. This is interesting. It's the inability to perform a skilled movement on command. Like if you ask them, show me how you wave goodbye, they can't do it.
Even if they could wave naturally if someone was actually leaving.
Precisely. Even if they do it automatically in context, it often goes along with aphasia.
Okay, now this is where it gets really interesting, I think. Focusing on specific injuries like stroke and TBI. Let's start with stroke and post-stroke depression, PSD. It seems common, but the source material says the location of the stroke is critical for how you approach it.
Oh, absolutely critical, especially right after the stroke, in the acute phase. Now, PSD is almost always linked with worse outcomes in daily living ADLs, activities of daily living. Patients just struggle more to get back on their feet physically. But the location tells you more. There's a strong inverse relationship, meaning the closer the front edge of the stroke lesion is to the left frontal pole, the more severe the depression tends to be.
So closer to the left front means worse depression. Why is knowing that so important?
Because it tells, this isn't just, someone being understandably sad about having a stroke. There's likely a direct biological cause rooted in that specific brain damage. Left anterior strokes significantly raise the odds of PSD compared to strokes further back. So knowing this pushes us towards treating the depression early and aggressively because it's probably organic and it's going to hinder recovery.
Makes sense. And what about the flip side, post-stroke mania?
Much rare, but definitely happens. And when it does, it's often linked to lesions on the right side of the brain, right hemisphere, could be cortex or deeper structures. Again, it just highlights how different the hemisphere's roles are in regulating mood. But diagnosis-wise, the DSM-5 keeps it fairly straightforward. If the mood or anxiety problem is clearly because of the stroke, it gets labeled anxiety disorder due to stroke or depressive disorder due to stroke, acknowledging that direct cause.
Okay. Let's switch to traumatic brain injury, TBI. Right after a TBI, behavior can be a huge challenge. How do we distinguish between agitation and aggression in that context?
Good distinction to make.
Yeah.
Agitation is more about excessive, kind of pointless motor activity, like pacing, restlessness, often driven by internal tension. Aggression, on the other hand, is overt. It's threatening behavior, maybe physical, directed outward at someone or something. And what's characteristic about aggression after TBI is that it tends to be very reactive and impulsive. It's often driven by that damage to the frontal lobes, impairing impulse control.
Right. And depression after TBI.
Also a very high risk, especially in that first year. Clinically, 3 symptoms really stand out for differentiating true depression in TBI patients. Feelings of hopelessness, feeling worthless, and anhedonia, that loss of pleasure in things.
And treatment.
Well, SSRIs, like sertraline, are usually considered first line. You have to be careful, though. Tricyclic antidepressants, the older TCAs, are generally avoided. Big reason is their side effect profile, especially the fact they can lower the seizure threshold. That's a serious risk you don't want to take with a TBI patient.
Definitely not. Okay, the sources show neuropsychiatry has a really wide reach. Let's look at some non-vascular causes, like infections. HIV/AIDS, for instance, carries a huge psychiatric burden, doesn't it?
Massive. The rate of major depression is something like 3 to 4 times higher than in the general population. And it's a really tragic cycle because it seems to work both ways. Depression itself can be a risk factor for getting HIV, maybe through engaging in higher risk behaviors. Then, once someone is infected, depression makes it much harder to stick with treatment, leading to worse medical outcomes. It's a vicious cycle.
Wow.
The sources even point to a specific personality type that seems particularly vulnerable. They call it the unstable extrovert. This profile involves, high risk-taking, impulsivity, constantly seeking rewards. And it seems to drive both the initial risk behaviors for HIV and the later problems with sticking to treatment. It's pretty striking that personality can play such a big role in an organic disease pathway.
That is striking. Huge implications for prevention. And thinking about recent viruses, COVID-19, we're seeing psychiatric consequences there too.
Yes, definitely. There was a large study looking at this. It found about a 5.8% chance of getting a new psychiatric diagnosis within 90 days after having COVID-19. The most common things showing up were anxiety disorders, generalized anxiety, PTSD, panic, and also depressive disorders. And what's really important is that this increased risk was still there even when they controlled for how sick the person got from COVID initially. Suggests it's not just a reaction to being sick, but maybe something more direct, neurological, or systemic.
Okay, let's touch on something quite dramatic. The rapid dementias, prion diseases like CJD.
Right. Creutzfeldt-Jakob disease. These are rare, they progress terrifyingly fast, and unfortunately, they're always fatal. We usually distinguish between the sporadic form, SCJD, which just happens, and the variant form, VCJD. That's the one linked to BSE or mad cow disease.
So,
What's notable about VCJD is, well, two things. It tends to hit younger people, and the first symptoms are often psychiatric.
before the dementia.
Yes, things like severe anxiety, depression, apathy, withdrawing socially, those come first, and the more obvious cognitive decline, the dementia, comes later. For all prion diseases, though, the focus of care is palliative.
Understood. Okay, let's wrap up this section with a really fascinating syndrome that can get missed. Catatonia.
Ah, yes. Catatonia is so important because it sits right at that intersection of motor control and psychiatric state. It reflects deep problems with starting and stopping movements, plus issues with cognition, emotion, and even autonomic functions like heart rate and blood pressure.
What are the key signs? I know the classic ones.
Right, the classic signs are things like catalepsy, where someone holds really awkward postures for a long time, and waxy flexibility, where you can passively move their limbs and they just stay there like a mannequin. But those are actually less common than some others that are easily overlooked. Things like mutism, just not speaking at all, extreme negativism, resisting any suggestion or movement, and just profound withdrawal.
And the treatment is quite unique.
It really is. One of the most remarkable things in psychiatry, actually. Patients often have this incredibly robust and fast response to benzodiazepines. There's usually a lorazepam trial to test this.
Wow.
And if that doesn't work, or if the person is extremely ill, electroconvulsive therapy, ECT, is considered the gold standard treatment. It can have efficacy rates up around 90%. The challenge, though, can be accessing it quickly due to state laws around informed consent, especially for patients who are so withdrawn or negativistic they can't consent. It can delay a highly effective treatment.
Okay, so we've covered a huge amount of ground here. We started with the idea that neuropsychiatry moves beyond general brain chemistry to a really differentiated view. We looked at circuits, assessment nuances, specific conditions like stroke, TBI, infections.
Exactly. And I think the core takeaway for you listening is that understanding these deep connections, how the physical brain structure, the lateralization, those fronto-subcortical loops, how all that dictates both normal function and pathology, that's really the essential framework. It's fundamental for thinking critically in any health or science field, really.
Absolutely. And that brings us to our final thought, something provocative to leave you with. We saw in the source material how certain personality traits, like that unstable extrovert profile, the risk-taking, reward-seeking one, were flagged as major risk factors, not just for behavior problems, but for actually contracting organic diseases like HIV or having worse outcomes after TBI. So if ingrained personality and behavior patterns are potentially among the biggest non-biological risk factors for organic brain disease, what does that really imply for where preventative medicine and psychiatry should be focusing their efforts? Something to think about. Thank you so much for joining us for this deep dive. We hope this exploration helps clarify those crucial links between the physical brain and mental health.